Now we have my cousin, who is a public health postgraduate nurse with an MSc in medical anthropology. She has worked in frontline humanitarian management, emergency, and the health program in several countries for more than 2 decades. She was the deputy head of the emergency unit in Spain from 2013 to 2020. So you have the floor. And I have the special pleasure to, because she was in Guinea-Bissau and did a lot of work for the population over there. Thank you very much.
Thank you very much. First of all, I got to ask my beautiful assistant to help me with the slides. Otherwise, I will get distracted. I'm not very good in passing and keeping attention. Well, when the lockdown was imposed in March 2020, I was actually court in Leeds here in the UK, and I was stuck there for a few months. But even so, I suppose I was one of the lucky ones that was able to work from home for a few months. And despite the restrictions in the UK, I felt that somehow what we experienced was much lighter compared with other places, based on the information I was getting from friends and colleagues from other countries. So I couldn't stop but thinking on the populations and the situations in places where I had worked not long before with Doctors Without Borders, particularly in places such as populations in refugee camps, in the middle of a conflict, those homeless, or those that simply can't afford to stay home with any livelihood. No? So in the coming 15 minutes that my presentation will last, more than talking about my experience in emergency response or the use of non-pharmaceutical measures in other epidemics, I would like to share with you an overview from a qualitative study I did as a part of a master's in medical anthropology. And the study shows the impact, the perception of the impact that the lockdown and restriction had in populations in middle and low-income countries. It is based on the perception of 23 humanitarian workers in several locations, so it's multi-local, and it includes narratives from several locations, many African countries, well, specific locations within African countries, Southeast Asia, Latin America, Middle East, and many locations. And the reason why I decided to do the study was the fact that lockdown was one of the most globalized measures, particularly in the first wave in 2020. And as it was mentioned earlier, this somehow was opposing recommendations and lessons learned from past epidemics, but also from institutions such as WHO. But also the fact that the implementation in the impact of lockdown and other movement restrictions in the so-called global south somehow still invisible, even today, 3 years later. So the study intends to bring those realities to light and give visibility to experiences and realities in those places. I will focus my presentation in 4 main lines. One of them is the lack of adaptation for the international response. Then I will talk about the impact in the delivery and access to health care, to health services. Also, although it was a specific section earlier on, I would like to mention briefly about a different way it has affected population in urban and rural areas. And more specifically, I would like to dedicate a bit of time on the impact on specific vulnerable groups, such as the irregular migrants and the refugees. But before that, I thought we need to understand the perspective from the people interviewed, being humanitarian workers. And we have to keep in mind that, for example, humanitarian organizations, of course, they were also very affected, obviously, for the lockdowns and restrictions. And for the first time, they faced many internal tensions and dilemmas, such as having to prioritize activities, stop some of them, either for resources shortages or for competing priorities. for new internal norms that they were imposed among many organizations, but overall also because the fear they have as humanitarian workers to be the one spreading the virus among remote communities, as well as for the paralysis of centralized organization model that was one of the key problems. Going to next. Actually, in all the slides, it's a bit heavy, but in all the slides, I have included quotes from the interview that I thought would help to illustrate some of the key points. And as I hope this one shows, it was a general perception that the recommendations from the WHO, they were designed only with the Western population in mind, without taking into consideration other realities that made them totally unfeasible for many. And with this somehow was raised questioning whether the international response could even constitute a betrayal to the Alma-Ata declarations. There are many, this failure to adapt or respond was attributed to many causes, but one of the ones was most mentioned was the fact that low-income countries, they have lack of opportunities to be part of decision-making international forums about global health. And that somehow we can say that it shows the hegemony that rich countries have still in decision-making about health policies, but also the fact that low-income countries are a mere object of discussion, but very rarely decision-making for this kind of international policies. These criticisms doesn't only refer to governments or to institutions such as WHO. It was also a criticism to NGOs themselves, that they were seen that they were driven by a very Eurocentric response model that failed to adapt and even to support some of the most vulnerable in such a critical time. Next. With the imposition of the lockdown, it became very clear that the implementation was never a matter of willingness, that the feasibility depends hugely in resources, income capacity. Social class was also widely mentioned, as well as profession and, of course, living conditions. The universalization of the measures without any cultural or contextual adaptation made the stay-home order something totally impossible for those that depend on informal economy, that actually in many countries represent the biggest proportion of the population. So this left those populations with an impossible choice in front of them: either follow the orders and go hungry, or pack the bags, return home, even if this implies even potentially expose themselves and risking to the virus. Next. The lockdown affects hugely the access to medical services and increasing the physical and economic barriers to access medical care. And we have to keep in mind that, for example, in most contexts, all these centralized community services, they were classified as non-life-saving. Therefore, they were suspended, even though temporary, but they were suspended for a long time. And this applied to not only humanitarian organization services, but government, private, and about all of them. Among the most affected, they were mentioned, all related to primary health care, including antenatal care. But specifically was a huge concern about the length of preventive activities that were suspended, such as mass vaccination campaigns, that even though they were resumed a few months later, some of them several months later, still we can say unknown the long-lasting impact that, for example, could have in the population on the risk or major risk of exposure to vaccine-preventable epidemics, for example, and other potential impacts. Even though the narratives, they were focused on the biomedical system, it was perceived that traditional systems, they were also very much affected. And this was partially because, for example, the closure of markets that prevent many populations to access and buy local remedies or traditional remedies, or to access to traditional healers that quite often they are based on the markets or nearby the markets, but also the closure of churches, mosques, and temples that prevent people to seek other ways of healing, as well as other means of support. The interruption of activities from humanitarian organizations, they were attributed to many causes, mainly to flights cancellation, stock ruptures. These include also the big gathering that it was seen that rich countries did in some essential items, such as masks, for example, that left many low-income countries without possibility to purchase any. But as I was mentioning earlier, one of the top causes mentioned was the fear of being the one spreading the virus in remote communities. It was perceived that humanitarian organizations, they failed to draw attention into the impact that having this entire focus only in COVID had for other acute needs. And for example, having a single focus in COVID left other acute needs totally neglected. Was mentioned yesterday. We have to keep in mind that for many populations in many countries, COVID was not a top concern. Still, for example, malaria, tuberculosis, malnutrition, they're among top killers. And even those, they were neglected because this international general focus in COVID. Also, to mention countries such as, for example, Democratic Republic of Congo, in 2020 they were facing a very, very complex situation. Not only they were facing a very complex internal conflict, but on top of that, they were facing an Ebola outbreak, on top of a measles outbreak, on top of a cholera outbreak, and then having all this international focus in COVID response left them with huge difficulties to respond and to have international support or even view into the situation they were facing. Of course, all these imply huge changes on health-seeking behavior. And for example, for many populations, the only option left was self-care. Self-care meaning also including family support, but they didn't have access to other services. And even a few months later, when many of the activities they were resumed, it was perceived that it was a significant drop in consultations, and this was attributed, that was specifically mentioned for Sahel region, but for some others as well. And they were mentioning that this could be related to a feeling of loss of trust from the communities toward the services. Next. The perceived impacts, they were mainly indirect, and there were noticed huge difference between rural and urban areas. For example, in rural sub-Saharan areas, where most of the population, they live in more basic and even very precarious conditions, but general population, it was seen that a lockdown was perhaps less noticeable a priori, because simply the implementation was, the compliance was impossible. However, the impact came with the reduction of services, that's as the ones I mentioned earlier, for example, and somehow this again shows the dependence that many low-income countries have still in external aid. But also it was mentioned the impact in regards of the school closures and the disruption of public transport. That was specific for many countries, that this broke the ties that many populations have with the cities, that for many is the only chances for them to trade, to go to the market, or even to access to hospitals. However, in urban locations with more police and military presence to reinforce the lockdown and bigger patterns of inequality, it was perceived that lockdown had a more visible face, and it affects significantly or more clearly to those depending on informal economy for the livelihood, that they lost the livelihoods. Going to next. Many participants, they describe what they mention as a phenomenon like a urban-rural exodus that was experienced in many locations. We mentioned earlier India, and that was in fact one of the places mentioned, between cities like Delhi towards rural areas in Bihar, for example, but also was mentioned in other countries in Latin America, such as Colombia, where the Venezuelan refugees that came a few years earlier, they flee back. For several months because the lockdown was causing a huge impoverishment of the population, so they have other option, or they took the decision to return to the places of origin. And with this, somehow we can say that rural areas, they face a double blow. For one part, losing the removal of livelihood, services, and on top of that, they have this massive displacement influx of people coming from the cities. It is somehow, I think, a paradox if we compare this urban-rural exodus that in the global north took place mainly among the wealthiest, that when the lockdown was announced, they flee to the countryside, to the second properties on the beach, on the countryside, just seeking comfort during the lockdown, while in the global south took place among the poorest simply to survive. They would mention other interesting movements that took place during the lockdown, such as what they described like a circular migration movement that was described on Peru, Colombia, Ecuador area, where many migrants, they were stopped from poor country to poor country for several months, unable to find means to stay in any of those. And we had to keep in mind that a borders closure doesn't mean there is no movement of population between borders, because, of course, many of these movements, they take place on clandestine routes. And many migrants all over the place, they were stuck in what they describe a kind of bureaucratic limbo for several months, unable to move on and unable to return. Next. So the collateral effects of lockdown, they were marked by aspect of intersectionality that was broadly mentioned yesterday, where being poor, women, and irregular migrant overlap to worsen the impact. And it was mentioned earlier the huge impact it has on women, and that was broadly mentioned. They didn't only lose the gateway to health services, jobs, any source of income, but they were also more exposed to domestic violence, gender-based violence, that in part this was attributed not only to an impoverishment, but also to the loss of social spaces and to the increase of alcohol consumption from household level from the partners, that this was specifically mentioned from many African contexts as well as Latin American contexts. It was mentioned the impact in children, specifically in young girls, related to the school closures that cause early marriages, increase in prostitution, unwanted pregnancies. But if there is a factor interacting with the others, worse the impact of lockdown, particularly in regards to exposure to violence, it is being a migrant or irregular migrant and a refugee. They were seen among the most marginalized, and part of this is because the invisibility is what increased the vulnerability of this group. As was mentioned yesterday, irregular migrants, they don't exist from governments, and we have to keep in mind the legal status will determine whether or not they have access to health services. They were double marginalized, first because they were held responsible to be the one spreading the virus, and then when the economic situation worsened, they were the one blamed for increasing crime and violence. There were several examples where not only they were affected because this bureaucratic limbo I mentioned, there were described situations where they view that lockdown has a punitive impact toward them. And for example, was a case mentioned on the in the Greece refugee camps, where the lockdown from the refugees lasts a lot longer than for the local population. Also the case in Bangladesh from the Rohingyas camps in Cox's Bazar, where, for example, the government took the decision during the lockdown to put a razor wire fence around the camp to prevent the refugees to leave the camp. And a few months later, during a fire, that's made for them impossible to flee the camp. But not only that, for the refugees, in order to leave the camps to go, for example, to hospitals, they were requested a negative COVID test, even when COVID tests they weren't available for them. Also, the situation that was very dramatic mentioned for Ethiopian refugees, the deportation process in Saudi Arabia, for example, was suspended during the lockdown and the restrictions. And this implied that the Saudi government took the decision to keep the Ethiopian refugees in detention centers for several months, with very bad conditions, crowded, what was the perfect ground for the spread of not only COVID, but tuberculosis, many other infections, but also where they were describing a situation of abuse toward them. Something similar also in Yemen, where Yemen is part of actually the migration route from Ethiopia, Somalia towards Saudi Arabia. And Yemen, as you know, is now in a conflict situation right now. And many of these refugees, because the disruption of the processes, the Ethiopian refugees, they were stuck in camps where they were instrumentalized for both parties on the war. And again, they were used and unable to move back or forward. Also was mentioned the situation for migrants in Latin America, where, for example, the US government, during the lockdown, they took the decision to continue with the deportation process. And at the beginning, where the prevalence in the US was very high, and in many Latin American countries, like El Salvador, was very low, if somehow resulted in huge fear, not only in the deportees, but also in the reception countries, that these people coming, they will be bringing the COVID to the communities. So it was very difficult situation for them, where they have to face even very long quarantines. Whenever was a flight arriving, they were holding quarantines. Next flight arrived in the same location, so they have to continue. So they stay several months. And I have many more examples, but I give an instruction that I'm passing the time. So just to conclude, with my last slide, I have tried to summarize some of the key points, some of which maybe I even escaped to mention. But basically, just to resume with one sentence, we can say that if you are poor, a girl, an irregular migrant or refugee living in a middle-income country, the international community and the civil society has failed to support you badly. And this is all. Thank you very much.